in our ED, syphilis, HIV and HCV screening program webinar, attendees are going to learn best practices and receive guidance on EDSP program workflows for patients with positive test results. So as always, EDSP webinar attendance by the clinical champion and patient navigators meets a program participation requirement of the contract, and we hope is very supportive to you. And ED staff and other staff supporting implementation of these workflows and interested in learning more should also attend. So please share that post-webinar email and recording with any of your colleagues unable to attend today. Next slide. So I am Cynthia Rohr, she and her. I'm the Bridge Program Director for EDSP. I'm on Ohlone land in Oakland, California. And Bridge is part of the Public Health Institute. As you know, we are extremely proud to administer EDSP for the California Department of Public Health and for you all, the 28 hospital emergency departments in 14 counties across the state who are joining us today. So nice to see you all introducing yourselves in the chat. Next slide. So for today, our objectives are to define what we mean in ED screening programs by linkage to care. Attendees will also learn key components of developing systems and standard operating procedures or SOPs to support this linkage to care. We'll map out the collaboration and shared responsibility between EDs and local health departments, and we'll discuss important implementation considerations like results disclosure and empiric treatment initiation within the ED setting. So I will now hand it over to our colleagues at the California Department of Public Health STD Control Branch, whose subject matter expertise supports TA and evaluation on this program.
Wonderful. Thank you so much, Cynthia. So as Cynthia mentioned, this webinar will focus on what happens when patients test positive for syphilis, HIV, and or hepatitis C as a result of your ED-based screening program. Next slide, please. As you can see, this slide depicts an example of a very high-level process map of what happens from the time a patient presents to the emergency department to the time that linkage to care has been confirmed for individuals who test positive. I do want to note that we recognize that this is an oversimplification and that there's a lot more work that goes into each of these steps, particularly around linkage to care. However, this provides a starting point to understand this basic flow. So starting on the upper left, first, a patient will present to the ED and receive an opt-out HIV, hepatitis C, and syphilis test. Next, the tests are resulted by the lab, and in this example, positive results are identified. Then, once results come back, they're disclosed to the patient, and empiric treatment is started if the patient is still in the emergency department as appropriate. Next, the linkage to care process begins, and the patient is referred to a clinic for additional treatment if indicated. The patient then attends their medical appointment, and finally, the ED patient navigator contacts the clinic to confirm successful linkage to care. Next slide, please. For this webinar, we'll be focusing on the last three steps in this process. What happens after a positive result is identified? And more specifically, the linkage to care process that occurs once an individual tests positive for syphilis, HIV, or hepatitis C. But before we dive in, let's define what we mean by linkage to care. Linkage to care is a patient-centered set of ongoing activities and relationship development between clinical staff and patients that's focused on building rapport, providing education and a point of contact, ensuring adequate treatment and access to care, and providing linkage to health, social, and partner notification services. For the purposes of this project, linkage to care is accomplished when the patient is seen by a healthcare provider to receive ongoing medical care for their infection, and this initial visit is verified. I do want to note that treatment may be initiated in the emergency department before the patient is discharged. Linkage to care is truly an essential part of the screening process, as it can establish patient-provider relationships, decrease care barriers, and increase the receipt of appropriate treatment, thereby reducing ED utilization and reducing the risk of ongoing transmission. Next, let's discuss how EDs can develop standard operating procedures to ensure successful linkage to care. Before you begin creating your standard operating procedures, or SOPs, it's important to determine who will be involved in drafting the document. We would suggest including the ED clinical lead, local health department staff, and clinic staff where clients are referred to for ongoing care in these discussions. Developing an SOP is an excellent opportunity to identify and engage with community providers and programs where patients can be referred to for follow-up care and treatment. Once you've identified who will be involved in drafting the document, set up a meeting to begin outlining your linkage to care process steps. Be sure to include details on how information will be shared across all of the organizations involved in linkage to care. And importantly, it's essential to also clarify roles and responsibilities and assign staff titles to each step of the process within your SOP document so that folks know who's responsible for which parts of the process. Next, I want to introduce Dr. Kathy Jacobson, who will be walking us through an example SOP. Dr. Kathy Jacobson is an American Academy of HIV Medicine and HIV Medical Association HIV specialist and board-certified family physician with over 30 years of experience. Her clinical care experience includes full-spectrum primary care, hospitalist, and ICU care, as well as emergency room consultations for complex HIV and STI patients, as well as hospitalist, urgent, and ICU care. Dr. Jacobson is currently the chief of the STD control branch at the California Department of Public Health and has extensive experience implementing ED-based syphilis, HIV, and hepatitis C screening programs. Dr. Jacobson, I'll turn it over to you.
Yeah, thanks, Ellen. And we're going to actually walk you through an SOP and the various steps that should be in it. This is going to be an example SOP that you can use. We do not expect that you're going to use it exactly, but it's sort of a starting place for you to begin to develop your own. And we'll give this to you in a Word document so you can just do track changes and change it however is appropriate for your particular ED. And I'm going to just start under the example standard operating procedures. And it is important to really kind of identify where each of these X's are, who is going to be having these conversations. So starting with, and this is a little bit, these first few steps look a little bit like that image that was shared, but the first steps are that persons having blood work at your ED will be advised by which staff. So is it going to be the ED clinician? Is it going to be the nurse triage staff? Is it going to be posters on the wall? Will it be part of the standard sign-in when individuals sign in, that they'll be advised that syphilis, HIV, and Hep C testing will be performed unless the person does not want the test performed, i.e. opt-out screening. And here's an example script that can be modified to fit your situation, but generally speaking, here's an example of how you want to say this. We do syphilis, HIV, and Hep C testing on everyone getting blood work in our emergency department. Please let us know if you do not want any of these tests. So the first step is really identifying who's going to be sending that message to the patient, because it's important that every patient that gets tested hears that message. Then the test will be drawn and sent to your hospital's laboratory. The results, this is standard. Of course, your results are entered by laboratory staff into the EMR, but any positive or reactive result should be flagged so that if the ED doc or ED provider is seeing the patient and a flag shows up that there's a potential positive there, they can prepare to disclose that particular result. And then confirmatory testing should be an automatic or reflexive process at your hospital. So ideally, you set up so that any positive or reactive test result has the confirmatory test automatically sent. Since today's topic is standard operating procedures, we're not really going to focus on what those reflexive tests are, but we're happy to share those with you if you have any questions about them via email. We also have both a webinar, and our next community of practice continues to be focused on what those confirmatory tests are. In next week's community of practice is next Wednesday morning at 8 a.m. We'll be talking again more extensively about those confirmatory tests. If you want to move to the next section. Perfect. So the next few steps are what will happen if the results do come back when the patient is still in the emergency room. And that is the goal of this project, is that you can set up a situation where the turnaround time on your test results turns around when individuals are still in the emergency room. We recognize, even if you set up the ideal setting, that there's going to be patients that leave AMA or patients that get discharged without getting those results. But we'll walk through if those results come in while someone's in the emergency room, and then what to do if it's after they're discharged from the emergency room. And these are the steps that you want to have in your standard operating procedure so that there's a plan for either situation. So when they return, when the patient's still in the emergency department, then typically those results are disclosed by the ED provider. And when appropriate, based on their clinical assessment, empiric treatment can be initiated right there in the emergency department. Some EDs like to bring the navigator in at the same time that they do the disclosure, but the provider does the disclosure, but the navigator is there. That's totally fine if you want to do that. I think it's sometimes helpful, and it brings the navigator's skills up to speed more quickly. When the treatment is initiated in the emergency department, we just followed through here with some recommended length of prescriptions that could be prescribed. Sort of the ideal length, because that would ensure that when patients do follow up for their ongoing care, they'll have enough medication to get them through until they get, for the purpose of HIV, put on ADOP, whatever situations need to happen so that their insurance can kick in and start taking over their prescription. So for HIV and hepatitis C, the recommended duration would be a 30-day supply of medications, with a follow-up appointment scheduled 1 week from the time of their emergency department visit. Of course, that is open to clinical judgment. If there's some reason that a provider has concerns about a patient, clearly, the next day, 2 days later, whatever they think is clinically appropriate. But if the patient is otherwise doing fine, then a 1 week follow-up is a good time frame, because that ensures that patients did get their medication if it was prescribed in the ED, and to check in to see if they're having any side effects from that medication. For patients with syphilis, ideally, those individuals, if deemed clinically appropriate, should get injected with benzathine penicillin G, 2.4 million units IM, should be given right there in the emergency department. And then follow-up is variable depending on their situation. So if the individual is determined to have primary, secondary, or early syphilis, meaning they've been infected with syphilis for less than 1 year, then as long as that patient was injected there in the emergency department, they've been adequately treated for their syphilis, they should be informed that the public health department is going to reach out to them to, in order to do follow-up partner services. So just make sure that they're advised that public health will be reaching out to them, but their follow-up appointment can be roughly around 2 to 3 months from their ED visit if they're otherwise doing fine. For patients suspected of late or unknown duration syphilis, meaning they've had syphilis for greater than a year from the time of your diagnosis, then they typically need 3 injections of benzathine penicillin G. And in the case that the ED provider determines it's appropriate to begin treatment there in the ED, they can have that first injection in the emergency department. And I strongly encourage that if the person's pregnant, but strongly also consider it if they're non-pregnant, especially as we get out of this benzathine penicillin shortage, which we're on the cusp of getting out of, supposed to be resolved come the end of June of this year. So for pregnant individuals, they need a follow-up appointment at 7 days. It can range between 6 and 8 days is acceptable, but they need that next injection basically at 7 days, because if they fall outside of that 6 to 8 day window, they have to restart their injections to ensure that they're adequately treated during their pregnancy. So we give a little window of 6 to 8 days, but the ideal day that they should follow up is at 7 days. Similarly, for non-pregnant individuals, you can also prescribe 28 days of doxycycline 200 milligrams, but I would still refer that patient for follow-up in 1 week. In case they didn't pick up that doxycycline and they didn't start it, then either giving them a follow-up injection when they come for those follow-up appointments, or just encouraging that individual to start their doxycycline. So that 1 week follow-up in both cases should happen, but it's extremely critical for a pregnant individual because they can only have benzathine penicillin G. They cannot take doxycycline during pregnancy. So we'll continue on if you want to move it up a little bit. So that's really just the recommended follow-up time frame after medication is initiated in the emergency department. Positive results need to be communicated daily with the public health department, and in some cases, patients will just be following up with public health departments. In other cases, there'll be a referral clinic that patients follow up with, but those communications should be daily so that patients do not fall through the cracks. And how those communications can happen really depends on your emergency department and your referral situation that you set up. When volumes are low, sometimes it's a daily phone call between the patient navigator. And if the patients are following up in the public health department or the clinic, just a daily call between those 2 individuals. Other times it's a secure listserv that's sent via email. In some cases, it's giving the referral clinic or the public health department and an individual in those locations access to your EMR, put them through your HIPAA training and have them have access to your EMR so they can then either get a listserv via EMR or they can scan the emergency department for individuals with positive tests. However you want to set that up, it's really between your emergency department and your referral clinic or your public health department, if that's where individuals are being referred, to make sure that there's this daily communication. And maybe I'll stop here for a minute before I have any further discussion to see if there's any questions about anything I've said so far.
Dr. Jacobson, this is Cynthia. I wonder if it would be possible for us to hold questions till the end, since we are going to recap some of these sections and people's answers might be clarified. With how do you, I feel open, up to you.
Yeah, I think that's fine as long as we don't have a lot of questions that are coming in. I just want to make sure that we don't move so quickly that folks are not able to follow. So I'll keep going, but certainly if there's any urgent questions, please feel free to speak up or put it in the chat. So now we're really moving to the role of the navigator. And the navigator typically is the person who's communicating daily with the public health department and the follow-up clinic. So I say I'm moving to the navigator role now, but actually that last section I just covered also typically is done by the navigator. So patient navigators should attempt to contact all patients who test positive. And generally speaking, the navigator is just going to work through their patients every day. But if there's a large number of patients and the navigator is concerned they're not going to get through all those patients, or even if there's a large number of patients and you know either the pregnancy status, the RPR titer, which a lot of times you're not going to know, or if you're aware that the patient is acute HIV or acute hepatitis C, those individuals should take priority in your list. So number one priority should be any pregnant people because of the risk of transmission. So those individuals you want to get treated for syphilis, for HIV right away. And so getting them immediately linked is critical. For individuals who have syphilis, if you know their syphilis titer, which often you're not going to know it, but if you do know it, and it's a high titer, and you know that that individual was not treated in the emergency room, then that would be another high priority individual to get in for treatment, because those higher titers increase their risk of transmitting to other individuals. And similarly, for individuals with acute HIV or acute hep C, again, this is if you know if they have acute HIV or acute hep C, you want to get those individuals in right away as well, because during the acute phase of HIV and hep C, the viral loads are very high, and so the risk of transmission is very high. And so that's why in a list of patients, if somebody's pregnant, they have high syphilis titers and were not treated in the ED, or they have evidence of acute HIV or hep C, those are your priority patients in that list. But ultimately, you want to get through the whole list. And this is for patient navigators. If there's no details regarding whether or not someone's pregnant, how high their syphilis titer is, or whether they have acute HIV or hep C, then everyone should be treated equal, and you just want to work through and make sure you get through all of your patients. And if you want to go ahead and move it up some, then typically the patient navigator will be asked to see individuals while they're still in the emergency department, because that helps them begin to develop that rapport. And then when they're seeing them, they can ensure that they have a correct address or living situation. You know, sometimes that living situation is they live under, 5th Street Bridge. So making sure that they gather the appropriate information so that those individuals can be followed up with by public health, that they get multiple methods of contact, whether it's an email, it's a phone number, it's text, snail mail, if it's contacting their brother, because that's the only way that they can get information, whatever is the method that they want you to contact them, making sure you get that method and some backup methods as well. And then they should assist in scheduling follow-up appointments and making referrals before the patient is discharged from the emergency department. Now we're going to talk about if the results actually come back after the patient leaves the emergency department. And again, that is not the goal. The ideal situation is that the results have a turnaround time that means they come back before most patients get discharged from the emergency department. But then in this case, the navigator would be reaching out to the patient, and the navigator would discharge or would communicate those positive results when they reach out to the patient and disclose them. And similarly, for patients that were discharged prior to getting their results, you can follow a similar prioritization that was recommended in the above number regarding pregnant individuals, high titers for syphilis, and acute HIV and Hep C. Again, that's if you know that information. Otherwise, just work your way through all of those patients that need disclosed. But I'm realizing what we didn't say here is if you have individuals who have not been disclosed to and individuals who have been disclosed to before they left the emergency department, you would want to prioritize amongst those groups reaching out to individuals who have not yet received their diagnosis. Because when the individuals don't know they're positive, they can go on and transmit to somebody else unknowingly. So getting that result to them would also be a priority. So I think we'll make one revision to the prioritization above, which is the first priority should be anyone who has not yet been disclosed to. And in seeing that revision that I'm recommending on this, what will happen is as you roll this out, you may find details that you want to add because it ensures better follow-up. This is really meant to be just a example to use, and this comes from an example that I worked with one emergency department with, which I had used an example I had used with another emergency department. So no two are going to be alike, but just the basic ideas you need to have in here. Okay, so for all patients, the patient navigator should be responsible for covering the following steps. And again, here I think we'll add one more, which is disclose results if they haven't been disclosed. But then from there, importance of adhering to treatment, linking to care and remaining engaged in care, really just educating patients about that importance, scheduling appointments as needed. The ideal situation is that when that person leaves the emergency department, they have in their hand their scheduled appointment date. Not a phone number that they should call to schedule an appointment, but they have a scheduled appointment date and time. And so that's something that you want to coordinate with your referral clinic or your referral public health department is how to give someone an appointment before they leave. Sometimes it's just follow up in 7 days at this appointment. Sometimes it's that the patient navigator actually has appointment slots that they can put the individual in to fill those appointments. So working out how you want to ensure that there is actually an appointment when that person shows up. Advising the patient that the public health department will reach out to them to ensure treatment and discuss partner services. Assessing social support needs. Do they need help with transportation? Do they need someone to, do they need Uber Health to come pick them up? Do they need a taxi to pick them up? Do they need any support for housing or food? And therefore you can link them to the appropriate social workers in your emergency department. And anything that can actively help that individual link to care in follow-up. Referring them to case management services. And then for individuals who test negative for HIV, offering them referral to HIV PrEP if they're interested. And for individuals who have a test positive for syphilis, also offering them referrals to DoxyPEP services. Okay, and if you want to move it down just a little bit further, we're almost done. The patient navigator should also ask each individual if it's okay with them if they confirm that the patient actually made it to their follow-up referral clinic appointments. This can just be a verbal confirmation that individuals are okay with the navigator following up with the clinic or following up with the patient themselves to make sure they made it into care. And then the navigator should follow up and confirm with the clinic that the patient did in fact make it into care. And then if they didn't make it into care, then the navigator typically is responsible for initiating efforts to contact the patient to get them into care. And often what emergency departments do is they give the navigator sort of X number of attempts, 3 attempts, 5 attempts, whatever number that you and the navigator settle on as an appropriate number of attempts to reach an individual. And then when they're not successful, then referring that individual to the public health department for ongoing efforts to contact the patient. And then the final part of this, if you want to just show the end, is that it's very helpful once you and your team have delineated these steps out and who's going to be responsible for the various steps, to then have everybody sign off on it. Because that way, you know that everybody's read it, everybody's in agreement with it, and everybody is expecting various individuals to do the different steps. And that's it. That's really an example. I'll reiterate that. This is just an example. Yours may look very different than this, but we wanted to just give you a starting point that you can then revise, edit, and or completely make your own version of standard operating procedures. With that, I think I'm turning it back to, is it Ellen or Cynthia?
Yep, it's back to me, Dr. Jacobson, and we can move back to the slides. Wonderful. Thanks so much, Dr. Jacobson, for sharing that standard operating procedure as an example. So Dr. Jacobson discussed many of the linkage to care SOP key components that are listed on this slide, from things like obtaining patient contact information to follow up by the patient navigator. So I won't go through these in too much detail, but we did want to reiterate some of the key components that you should consider as you craft your SOP so that you have them to refer back to. And as mentioned, please note that these are general considerations. Your ED's standard operating procedures should be tailored to the needs of your setting. Next slide, please. And this next slide includes a couple of additional key components to consider. So feel free to refer back to these as well as you begin crafting your standard operating procedures. Next slide, please. Next, we wanted to highlight the role of the patient navigator in linkage to care. The role of the patient navigator is essential to the success of an ED screening program. Patient navigators connect with patients who test positive to educate and support linkage and engagement in care by contacting referral organizations on the patient's behalf to schedule appointments. They also coach patients on harm reduction, safer sex practices, and prevention services. In addition, they help reduce barriers to treatment and assess social needs like transportation or housing. And lastly, they link patients to local ongoing comprehensive care services and community programs. Next slide. I also want to note a couple of special considerations related to patient follow-up. So as Dr. Jacobson mentioned, firstly, follow-up with all patients should ideally take place within 24 hours of their ED visit or on the next business day if there isn't navigator coverage, for example, on weekends or holidays. And next, in a given day, consider prioritizing patient follow-up as follows. So first, follow-up with pregnant patients, then patients with suspected acute HIV, high syphilis titers, neuro or ocular syphilis or acute hepatitis C. And lastly, follow up with all other patients. Next slide, please. So in developing your linkage to care SOP, collaboration with your health department is critical, as linkage to care and ensuring treatment is often a shared responsibility between emergency departments and their local health department. And oftentimes there's overlap between the patients who test positive in the ED and priority patients for local health departments. Local health departments can support EDs in their implementation of EDSP, particularly around linkage to care and ensuring treatment. What this looks like will vary by local health department, which is why it's critical to meet with your health department to learn more about their current processes and what support they may be able to provide to your ED screening program. On this slide, we've outlined different ways that health departments may be able to provide support, and we hope that this information will be useful to inform discussions with your health department. So health departments can provide support in education and support in answering complex patient management questions, historical diagnosis and treatment record searches to support treatment, They support ensuring treatment, and health departments can also conduct field outreach to locate patients and support linkage to care. And they can refer patients to DAC-PEP and HIV pre-exposure prophylaxis, or PrEP, as well as other prevention services. And lastly, health departments can assist in identifying and finding partners and ensuring treatment or prevention. As mentioned, you'll want to schedule meetings with your health department to discuss establishing your linkage to care SOP, along with who will be responsible for which pieces of the protocol. And we're happy to facilitate connections between EDs and health departments. And if that's something that your ED is interested in, please feel free to reach out and let us know. So what does this collaboration look like in practice? On this slide, we'll outline a few models that we've seen in California emergency departments highlighting collaboration between EDs and health departments. So in the first example, the linkage to care navigator is based in the emergency department and conducts follow-up and linkage to care, consulting the health department for diagnosis, testing, and treatment information as needed. In this next example, the disease intervention specialist, or DIS, based at the health department, receives referrals from the ED and provides follow-up and linkage to care. This requires daily communication between the ED and the health department. And lastly, there are several local health departments that have embedded DIS in the ED to provide follow-up and linkage to care. I do want to note that for the purposes of EDSP, in this model, the embedded DIS would fulfill the role of your ED's patient navigator or navigators, and would be responsible for providing full scope navigation services, having periodic collaborative meetings with the clinical champion, and attending EDSP webinars and community of practices. If you have questions about how to leverage EDSP funding to support this model, please feel free to reach out to Cynthia with the Bridge program. And as a reminder, these are just a few examples of ways folks can partner. Ultimately, regardless of the specific process you implement, it's critical that prior to rollout, you determine what your processes will be for linking patients who test positive to care, including identifying who at the hospital, clinic, or health department will ensure seamless linkage to care so that patients don't fall through the cracks. In order to set this collaboration up for success, it's important to also ensure the bidirectional sharing of data between EDs and health departments for timely linkage to care and treatment. To accomplish this goal, some EDs have set up processes for bidirectional data flow, such as granting health department staff access to the ED EHR as per their internal protocols, creating a memorandum of understanding or MOU about what data will be shared and how it will be shared, or embedding local health department DIS staff directly into the ED to support patient navigation and linkage to care. So why is linkage to care important? Hopefully the previous slides have driven home these points, so I won't go into these in too much detail. But to summarize, linkage to care can increase patient participation in care, increase relationship building and decrease care barriers, establish patient-provider relationships, and increase the receipt of appropriate treatment and partner services, thereby reducing morbidity, disease progression, and ED utilization. Next, I will hand it over to Cynthia from the Bridge program to discuss other implementation considerations.
Okay, thank you. Next slide. I want to just briefly give this visual here about disclosure of results. Dr. Jacobson referred to this previously. The best practice to quickly and effectively link patients to treatment and care is that results return while they are in the ED. In that case, as mentioned, typically the ED provider will disclose results. They will refer the patient to the patient navigator, ideally with an in-person handoff, or the two may collaboratively disclose and guide the patient on to next steps. And then when appropriate, the provider will initiate empiric treatment in the ED setting. Of course, we understand the reality for many of your sites who are just getting started with implementation and or are building capacity for quicker turnaround of lab results is that positive results may return after the patient has left the ED. So really important either way that who is going to disclose results is clearly outlined in your SOP. In this case, it will likely be the patient navigator or in the model mentioned previously, perhaps a local health department DIS worker who is going to start contacting the patient to disclose results, begin education, and linkage to care. Some EDs may already have a workflow, for example, for nurses to disclose diagnoses while in the ED. Those sites might use their existing processes or refer the patient to the patient navigator. So in the next slide, I want to just share some steps to get results. So this might be brand new for some of you. Perhaps it's new for these types of infections. Start off, warmly introduce yourself and say that you have test results to discuss. Inform the patient using direct language. So, Cynthia, we received your test results. You tested positive for syphilis, meaning you have a sexually transmitted infection called syphilis. Syphilis is completely treatable. I'm here to help you with that and answer your questions. And then I'm pausing. So pause to offer the patient space and autonomy to take in this information. This might be surprising or brand new for the patient. For others, it might be something that they have known or suspected for some time. Next, meet the patient where they are with information and support. Patients' reactions and needs will vary, so take a stigma-free approach and a patient-first approach. Normalize whatever they are feeling and follow their lead. Finally, address any immediate questions or concerns. If a patient has a question in their mind, they may not be able to hear as you map out next steps. So ask about immediate questions or concerns, and then map out next steps. Next steps might look like treatment options, partner treatment and prevention plans, all of which should be rooted in the patient's goals, preferences, and life circumstances, and then linkage to care and support services. So I want to be sure to give time for question and answer. Dr. Jacobson mentioned previously that she will be talking about empiric treatment and treatment in the next community of practice and the next webinar. So I think we can go ahead and transition through the next few slides. Dr. Jacobson, if do you agree that we can
Yes.
head on to Q&A? Thanks. Okay, thanks for confirming. So we can go ahead and when you get the slide deck, you'll get this sneak peek of some information and references about empiric treatment and syphilis empiric treatment. And next, I want to go over some additional linkage to care resources. So as always, the QR code will take you to the EDSP website. We have an extensive library of resources there, including toolkits for patient navigators. That was a question previously about training for navigators. And these specific resources linked here will also be included in the post-webinar email. Next slide. I want to also give another sneak peek for the patient navigators. Those who are on board have already received a welcome email from us and an onboarding survey to inform our navigator Slack channel that Bridge is hosting, which will be coming very soon as a place to share resources, network, post questions, and kind of co-create that space together. And let's go ahead. Thanks. You can go to the next slide. Let's just transition right into Q&A. I know there have been a few questions in the chat. Folks, I'll give you a moment to put questions into the chat so that we can start answering some of them. Doing a little review here. Well, there's one question that perhaps our CDH partners could address. With HIPAA concerns, the question is about, even with verbal permission from patients to call other partner clinics to follow up on and confirm linkage to care. Any tips from our panel about ensuring following HIPAA processes and also being able to confirm linkage to care with partner clinics?
Here, I'll jump in here, Cindy. I think that, so the important thing here is really falls back on the setting up this standard operating procedure, identifying who your point of contact is in that clinic. So then this becomes part of your overall services. When individuals sign their HIPAA protection, when they're accessing care, part of that is that you only need to know results will be disclosed in order to facilitate an individual's care. So if you set up these operating procedures and you have identified who in that clinic you're contacting, or who in the public health department you're contacting to refer that patient, and then you're going to confirm that they followed up, that's part of those ensuring their care. And that's part of the reason to have standard operating procedures. So then there's no concerns about those pieces. Let me know if that effectively answered that question or not.
Wonderful, thank you. And one of our partners have just reiterated that for their site, and really broadly, that it's considered continuation of care post ED discharge, and so that is protected under HIPAA. Thank you so much for sharing that experience, and thanks, Dr. Jacobson. I know there have been a number of clinical questions in the chat that you've addressed there as well. One is before we step into more technical clinical questions. One is a more broad kind of operational linkage to care question. Do we still need to do linkage if a person just has syphilis and not HIV or HCV?
Yeah, great question. So if the clinical person who's managing the patient determines that that individual has primary syphilis, secondary syphilis, or that they've been infected with syphilis sometime in the last year, then the treatment is that single dose of benzathine penicillin G. But you still want to refer them for a follow-up appointment roughly around 2 to 3 months down the road, because what we like to do is follow up their RPRs basically quarterly until we confirm that they either go to non-reactive or we confirm adequate treatment for an individual. So that's the reason to have them follow up. But the timeline is more extended for when they need to follow up. But they should also be advised that the public health department will be reaching out to them, because they're going to contact them to try to understand who their partners are, so that they can identify those individuals and treat those individuals as well, so they don't get reinfected.
Wonderful. And this isn't quite the question, and I'll just kind of reiterate that those patients will also benefit and need to connect with the patient navigator on other areas of their life, things they might need as far as supportive services as well. Great. There's a thank you for that question. I'm curious if any of the, as I mentioned, I know quite a few of the clinical questions, Dr. Jacobson, you've been able to answer in the chat. Was there anything that was asked there that you wanted to in particular highlight? Oops, and I think you're still on mute.
Oops. Yes, I was going to say, actually, if okay, I'd like to highlight both of them because they're both important questions. So one question was, if your clinical impression is that this individual has late or unknown duration syphilis, meaning they've been infected for a year or longer, if you give that injection, that first injection of benzathine penicillin G in the emergency department, do we actually want them to then prescribe doxycycline? And here's why we said to do both. So you prescribe doxycycline and then you refer them for follow-up in a week. When they come in for follow-up, then the provider who's seeing them in follow-up can determine, have they actually picked up the doxycycline and are they taking it? In which case they can just let them take the doxycycline. If they haven't, then they can inject them with their second and bring them back for their third injection. It is reasonable to just give them doxycycline if your interpretation of the patient in your clinical impression is that that individual is someone who's going to take that medicine and is going to follow up. But if you have any concerns that they're not, that's why we recommend that first injection. Prescribe the doxycycline and bring them back in a week, and then let that follow-up provider determine, do you just keep giving or just keep giving the 2 more shots of penicillin, or do you or are they taking the doxycycline and you can let them complete their course? The other question was, what do you do if you have a pregnant person who has syphilis, who is allergic to penicillin and can't take doxycycline because doxycycline is contraindicated during pregnancy? So this is really a critical question. And first and most important is that pregnant individuals with syphilis absolutely need to be treated during that pregnancy, or they are at risk of transmitting to their infant their syphilis. And then that infant is committed to 10 days of IV penicillin at delivery. And so if you have a pregnant individual who has syphilis, who is allergic to penicillin, that individual actually needs to be admitted to the hospital and go through penicillin desensitization, which is, there's protocols out there for desensitization. Once they're desensitized, then they can complete their treatment. But it's really critical that a pregnant individual does get treated during their pregnancy. And sadly, we've seen some instances where in this very circumstance, people didn't get treated and then their infants go on to have congenital syphilis.
Thank you. And I'll just give a little more time here before we wrap up. I'll just name that we will share in the next webinar an example of kind of patient cards and signage for your ADs so that you can start to really spread that culture of routine opt-out testing. And along with the resources and recording, we will include a copy of the presentation as well. Okay, so let's start to wrap up with some next steps for you and your team. So meet as a team to discuss creating protocols and processes for linkage to care. We hope that you can use these resources in this webinar to really just use the template as a starting place that you can adapt to your realities of your site. Contact your local health department and referral clinic partners to begin discussions and start planning, start designing your standard operating procedures, your SOPs for linkage to care. Draft those SOPs, And then again, join us next week for the monthly community of practice. It is on Wednesday, the 21st from 8 to 9 a.m. And reach out as needed. I'll end with our contact information as always. We would really appreciate your feedback on this webinar. It helps us know what you need. So on the next slide and in the chat, if you could take a moment to either scan the QR code for the survey, or we've also dropped it in the chat. We've really appreciated all the feedback that we've received from you all so far and tried to incorporate in moving forward. And I also see a great question about funding options for treatment for medication to treat. So we can save that for community of practice next week. And I'll end on our contact information, which I hope you all have at this point. In the next slide, please reach out for anything you need. Please utilize the website for the resource libraries that are there, the recordings of past webinars, and keep a lookout for the post-webinar email. Thank you all so much. We really appreciate your time and your active participation.